Good morning and welcome to Grand Rounds. This morning we are happy to welcome Dr. Silvana Carr. Dr. Carr received her medical doctorate in pediatrics at the Federal University of Bahia. She completed her pediatric residency at Mount Sinai Hospital Medical Center and her fellowship at the University of Tennessee. She's board certified in pediatric infectious disease and is assistant professor at the University of South Florida College of Medicine. This morning, Dr. Carr will be speaking to us on emerging infectious diseases, macrolide-resistant mycoplasma pneumonia infection. And I want to just add that afterwards, when there are questions, we will be using a microphone, so please use it if you have questions. Please welcome Dr. Carr.
Can you hear me? So, good morning. Thank you, Dr. Zenili, for the invitation to talk this morning in the Grand Rounds. Today, I'll give you overview about mycoplasma pneumonia infection in children and discuss some aspects of the macrolide-resistant mycoplasma pneumonia emergency. So mycoplasmas are the smallest self-replicating organisms, both in cellular dimensions and genome size, that are capable of cell-free existence. Mycoplasma pneumonia causes disease only in humans. And this microorganism is one of the leading causes of community-acquired pneumonia. So, Knockhard and Rowe in 1896 reported the cultivation of the agent of contagious bovine pleuropneumonia that on that time was a cause of severe and widespread disease in the cattle herders. So that was the first time that a mycoplasma species was isolated. Mycoplasma name comes from Greek mykes, that means fungus, and plasma, formed, and it was proposed in 1950s, replacing the term pleuropneumonia-like organisms, referring to organisms similar to the causative agent of contagious bovine pleuropneumonia. It was later found that the fungus-like growth partner of Mycoplasma mycoides is unique to that species. Mycoplasma pneumonia was first isolated in tissue culture from the sputum of a patient with primary atypical pneumonia by Dr. Eaton in 1944, and the microorganism was known as Eaton agent. It was initially considered to be a virus until it became clear that antibiotics could be effective against it. In 1961, Marmel and Goodburn found out that the Eaton agent was a pleuropneumonia-like organism and not a virus. In 1962, Chenok grew the Eaton agent in cell-free media. He noticed that the microorganism could produce granular colonies with an embedded center that had an appearance of fried egg. And later on, in 1963, he proposed the change in the taxonomic designation of the Eaton agent to Mycoplasma pneumonia. Mycoplasma is part of the family of the Mycoplasmataceae. The family has two genus, Mycoplasma and Ureaplasma. At least 17 Mycoplasma species have been isolated for humans. 4 types are responsible for most of the disease in humans: Mycoplasma pneumonia, Mycoplasma hominis, Mycoplasma genitalium, and Ureaplasma species. Mycoplasmas are small, spindle-shaped cells. They are very small, 1 to 2 micrometers long and 0.1, 0.2 micrometer wide. They don't have a cell wall. They are prokaryotes, but they don't have a cell wall. And this feature is responsible for some of the biological characteristics of these microorganisms, such as the lack of green-stain reaction and the non-susceptibility to many antibiotics, including beta-lactams. It has a very small genome with limited biosynthetic capacity. It has a cell membrane that contains sterols that is not seen in any class of bacteria or viruses. It has a fastidious growth on cell-free media in vitro. So this picture shows the elongate shape of the Mycoplasma pneumonia, and on the tip has the attachment organelle that is a structure that is very important in many aspects of the life cycle and pathogenesis of these microorganisms. This other picture shows the fried egg appearance of the Mycoplasma pneumonia colonies in the agar. They are granular with a dense center and a lesser dense periphery. So mycoplasmas are not found freely living in the nature because they depend on a host cell to supply the necessary nutrients. However, in humans, intracellular invasion has not been observed after infection in the bronchial epithelial cells. However, the microorganism has been found attached to the cell walls, and site adherence is an essential prerequisite in production of disease. So, mycoplasma attached to the epithelial cells using its attachment organelle that contain two adenosine, P1 adenosine and P41 and P24. Those proteins are required for attachment of the mycoplasma to the cell wall and glottine motility. The P1 adenosine is especially important because mycoplasmas who are devoid, who lack this protein, they are non-adherent and avirulent. Here this picture is, I thought was very interesting because it shows clearly the mycoplasma with its attachment organelle in close contact with the epithelial, respiratory epithelial cells of a mouse in the animal laboratory model. So mycoplasma has several virulent factors. So the discovery of the community-acquired respiratory distress syndrome toxin, CARDS, displayed the dogma that mycoplasma were devoid of exotoxin. It is an ADP ribosyl transferase that has a similar sequence homology to the SC1 subunit of pertussis toxin. It stimulates the production of cytokines in the lower respiratory tract, causes ciliolastasis, nuclear cell fragmentation, and eventually airway damage. Also, studies have demonstrated that the amount of toxin produced correlated with disease severity. The other virulent factor of mycoplasma pneumonia is the production of hydrogen peroxide. It is produced by the metabolism of the glycerol present in the host cell's membranes. In the erythrocytes, the hydrogen peroxide causes the loss of the reduced glutathione, resulting in denaturation of the hemoglobin, peroxidation of the erythrocytes' lipids, and eventually hemolysis. This picture summarizes the pathogenesis of the human mycoplasma pneumonia in the lower respiratory tract. So after inhalation, mycoplasma pneumonia attached to the ciliate bronchial epithelial cells using its attachment organelle. So, and then it starts to produce hydrogen peroxide and cardstoxin. Glycolipids present in the surface of the mycoplasma will stimulate the production of interleukin-6 and other cytokines, resulting in a local infiltration of neutrophils. So, in the lower respiratory tract, mycoplasma will be opsonized by antibodies and complement, and phagocytized by activated macrophages. Macrophages will activate multiple cytokines, including interleukin-18 and interleukin-8. Those cytokines, they are very important because the amount of those cytokines in the lower respiratory tract is related with the severity of mycoplasma pneumonia. The interleukin-8 is going to stimulate the proliferation of lymphocytes, and the interleukin-18 is a potent neutrophil chemoattractant. Subsequently, is going to have a local exudate comprised of lymphocytes and neutrophils in the lower respiratory tract. So, a further amplification of the immune response will cause a proliferation of more lymphocytes, production of immunoglobulins, production of more cytokines by the T cells, triggering an inflammatory cascade. The activation of macrophages and killing of the mycoplasma pneumonia in the lower respiratory tract depends on the toll-like receptors 1, 2, and 6. So mycoplasma pneumonia is divided into two major genetic groups based on the sequence difference in the P1 protein gene, subtype 1 and subtype 2. Both subtypes and multiple variants of those subtypes may circulate at the same time. Alternate predominance of subtype 1 or 2 strain in a population has been documented. However, correlation between subtypes and disease severity or antimicrobial resistance has not been confirmed. So mycoplasma pneumonia infection occurs endemically worldwide in many different climes. Climate and geography are not thought to be a major significance. Is not thought to be of major significance. Epidemics usually occur every 4-7 years, and they are thought to be related to the weaning of herd immunity and introduction of new subtypes of mycoplasma in the population. Outbreaks usually occur in summer and early fall, but they can occur in any time of the year. Outbreaks have been documented in communities and in closed or semi-closed settings such as military bases, hospitals, religious communities, and facilities for mental or developmentally disabled. So the attack rates on those settings are quite high, ranging from 25 to 71%. Intrafamily transmission is well documented, and the index case usually is an older child, 5 to 14 years of age. Mycoplasma is transmitted from person to person through droplets, and the incubation period is 1 to 3 weeks, ranging from 4 to 23 days. Mycoplasma pneumonia can induce upper and lower respiratory tract infection from infancy through old age. However, school-aged children and adolescents are the ones most likely to have mycoplasma pneumonia infection. And the increase of severity of the symptoms is also more common in this age group. In children, tracheobronchitis is the most common clinical presentation of a mycoplasma infection, and pneumonia is the most severe form of the infection. Mycoplasma can cause up to 40% of cases of community-acquired pneumonia, and as many as 18% of the cases requiring hospitalization in kids over 5 years of age during epidemics. During the endemic periods, Mycoplasma responded for 4 to 8% of the community-acquired bacterial pneumonia. Most infections occur among outpatients. So that's the reason we call the name walking pneumonia. Most infections are mild. There are is postulated that many cases are asymptomatic. However, the asymptomatic status is less common in children than in adults, maybe because the degree of protective immunity for reinfection that is present in the adult population. However, Mycoplasma pneumonia remains a significant cause of community-acquired bacterial pneumonia in adults requiring hospitalization. It is estimated 2 million cases annually, resulting in around 100,000 hospitalizations in the U.S. Mycoplasma is second only to Streptococcus pneumoniae to cause community-acquired pneumonia in the elderly population. However, because many of the infections are mild, because of the similarity of the presentation of Mycoplasma pneumonia with other infectious etiologies of pneumonia, and also for the fact that there is a lack of a reliable point-of-care test to confirm the diagnosis of Mycoplasma infection, it is believed that many infections are likely to be undetected, and the true prevalence of Mycoplasma pneumonia infection may be underestimated. So Mycoplasma pneumonia is not considered to be part of the normal human respiratory flora. However, it can persist for variable periods of time in the respiratory tract after infection, despite adequate antibiotic therapy. So the carrier status is thought to be maybe secondary to a failure of the natural immunity to eliminate the microorganism completely, or maybe because of the antibiotics used to treat Mycoplasma pneumonia, they are bacteriostatic instead bactericidal, so they don't kill all the microorganisms. The carrier status works as a reservoir for spread of Mycoplasma pneumonia to others. So tracheobronchitis is the most common presentation of Mycoplasma in children. It starts with unspecific symptoms, headache, chills, myalgia, sore throat that does not show exudates, with or without cervical lymphadenopathy, conjunctivitis, and ear pain. Otitis media-sized infection may be present. So fever ranging from 101 to 103 is common and usually lasts about 1 week in uncomplicated cases. Mycoplasma produces a dry cough that in 3-4 days starts to produce some mucoid sputum. The whole disease lasts 3 to 4 weeks. The cough lasts 3 to 4 weeks in older children and adolescents, an average of 54 days in adults, so much longer. And the chest soreness may be a complaint due to the protracted cough. Children younger than 5 years are more likely to have coryza and wheezing. Progression to pneumonia is uncommon in this age. Mycoplasma pneumonia respond to up to 5% of bronchiolitis cases in young children. Bronchopneumonia occurs in 3 to 10% of the infected persons. The older children, 5 to 15 years, are more likely to develop bronchopneumonia, sometimes requiring hospitalization. So, despite the fact that most of the infection caused by Mycoplasma pneumonia are mild, 0.5 to 2% may progress to fulminant pneumonia with fatal respiratory failure. It's more common in adolescents, while the mild infections and asymptomatic cases are more common in adults. Persons with functional asplenia, Down syndrome, and other immune disorders, they are at risk of developing fulminant pneumonia due to Mycoplasma. So it is well known that mycoplasma can cause a broad array of extrapulmonary manifestations. So given the fact that the microorganism can invade the bloodstream, almost any organ system can be affected. The extrapulmonary manifestations occur in 25% of the infected persons. It can occur before, during, or after the respiratory disease, or can occur in the absence of a respiratory symptoms in 20% of the cases. In the cases where the respiratory symptoms occur, usually the extrapulmonary manifestations develop 1 to 2 weeks after the onset of the respiratory symptoms. The extrapulmonary manifestations is thought to be secondary to autoimmune reactions caused by the mycoplasma pneumonia infection. However, the microorganism has been detected by PCR in many cases, so that direct invasion must always be ruled out. Central nervous system. So encephalitis is the most common neurological manifestation in children. It's more common in children than adults. And mycoplasma responds for 13% of all encephalitis cases. So mycoplasma can also cause aseptic meningitis, acute disseminated encephalomyelitis, cerebellar syndrome, post-infectious leukoencephalopathy, strokes, striatal necrosis, psychological disorders as acute psychosis usually are secondary to central nervous system vascular injury caused by the microorganism. In the peripheral nervous system, mycoplasma has been described to cause neuropathies, radiculopathies, optic neuritis, and Guillain-Barré syndrome. 5 to 10% of the DBS cases have been associated with a preceding mycoplasma pneumonia infection. So it is thought that during the mycoplasma infection, there is a production of some antibodies called galactocerebroside antibodies as a result of the cross-reactivity of the mycoplasma glycolipids. And it results in the development of the Guillain-Barré syndrome. Those antibodies are more likely to be found in the Guillain-Barré associated with mycoplasma than in the cases that are associated with Campylobacter jejuni. Mycoplasma can also cause transverse myelitis. Dermatological disorders are the second most common common extrapulmonary manifestation. So it seems like central nervous system manifestation, peripheral plus central nervous system infection are the most common one, followed by dermatological disorders that can occur in up to 25% of the patients with mycoplasma pneumonia infection. So you may see bullous dermatitis, ulcerative stomatitis, bullous exanthemas. Mycoplasma may be caused as Stevie Johnson-like syndrome that is described to be milder than the drug-induced Stevie Johnson. It also can cause urticaria, anaphylactoid purpura, and erythema multiforme. Hematological disorders are rare as an extrapulmonary manifestation of mycoplasma infection, but they are severe and they are more common in children. So most commonly, mycoplasma can cause a hemolytic anemia by the production of IgM autoantibodies against the E antigen of the RBCs. So those autoantibodies are the ones responsible for the cold agglutinin phenomenon. And it can be life-threatening in patients with hemolytic anemia. Mycoplasma also can cause TTP, DIC, and ITP. And there are 2 cases in the literature describing the development of aplastic anemia during the mycoplasma pneumoniae pneumonia. Cardiac disorders occur in 1 to 8.5% of the patients. Myopericarditis, cardiac tamponade, and endocarditis are the most common ones. The cardiac disorders are more common in adults than kids. The majority do not have a concurrent pneumonia. It is considered autoimmune, but mycoplasma has been isolated in culture and identified by PCR in some of those cases. Mycoplasma can cause musculoskeletal manifestations such as septic arthritis, osteomyelitis, and rhabdomyolysis. Septic arthritis is a known complication of mycoplasma pneumonia infection in patients with antibody immune deficiency. So mycoplasma pneumonia has been isolated from the synovial fluid several times, but the microorganism has also been found to cause reactive arthritis. And also, in 14% of the cases of pneumonia, myalgia, arthralgia, and polyarthropathies may be present, and they may last for a long period of time, weeks or months. Occasionally, we may see hepatitis, elevated of the liver transaminases, and pancreatitis in patients with acute mycoplasma pneumonia infection. Mycoplasma can cause renal manifestations as well, acute glomerulonephritis of various types, nephrotic syndrome, interstitial nephritis, and IgA nephropathy. And the microorganism has been detected by PCR in one case of membranoproliferative glomerulonephritis, and in one case of interstitial nephritis. Ocular manifestations may be caused by mycoplasma, and they may be present as conjunctivitis, iritis, anterior uveitis, retinitis, retinal hemorrhages, and optic nerve swelling. It is assumed to be related to an autoimmune response to the mycoplasma pneumonia infection. And to date, there are no reports isolating the mycoplasma from the ocular tissue. Okay, so the role of mycoplasma pneumonia infection in the pathogenesis of asthma has been a subject of continuing debate. So the explosive release of pro-inflammatory cytokines in association with the mycoplasma pneumonia infection has been implicated as a mechanism that can lead to or exacerbating a underlying chronic lung disease such as bronchial asthma. So there is little question that mycoplasma infection, either alone or in combination with respiratory viruses, is capable of inducing asthma exacerbation. However, the studies in the literature show that the proportion of asthma flares where mycoplasma pneumonia is identified is low, 4.5 to 12.4%. Then two relevant questions are left. Whether is mycoplasma pneumonia is a primary cause of asthma, or mycoplasma pneumonia infection is at least a cofactor in asthma development. Mycoplasma pneumonia infection seems to be a precipitating factor for asthma development in predisposed persons. Some studies showing that mycoplasma toxin in patients with the infection might present a causal factor in the cause and exacerbation of asthma. So among of those toxins, the cardiotoxin. However, the evidence that mycoplasma pneumonia plays a role in inducing asthma onset remains scarce and controversial at this time. So the infection caused by mycoplasma pneumonia shows unspecific findings on the CBC, electrolytes, and the liver and renal studies. The CBC may show hemolytic anemia. The CRP and SCR might be elevated in severe case, but they are inspecific. So the LDH has been considered a biomarker to predict more severe or refractory disease at the early stage of hospitalizations, in the cases of severe infection that require hospital admission. And also might help to identify subjects for the steroid trials at early stages. Most of the studies show that the optimal cutoff of the LDA level is 379 international units. It has a sensitivity of 48%, that's kind of low, but the specificity is high, 85.8%, to predict the development of more severe refractory disease. So the cold agglutinins that are thought to be IgM antibodies against the antigen E of the human erythrocytes appears 1 to 2 weeks after the symptoms onset in about 50% of the cases of Mycoplasma pneumonia infection. It may persist for several weeks, so it's not helpful to tell about, to inform you about acute infection. Also, it does not have a good specificity. It may be present in cases of adenovirus and influenza infection, and in various bacterial and rickettsial infection. So Mycoplasma pneumonia can cause a broad array of radiological manifestations, radiological findings, and a broad array of radiological finds that can mimic many lung diseases. So the most common is a PET airspace consolidation and ground glass opacities. And usually the disease is predominant in the lower lobes. Unilateral pleural effusion is particularly common in children, around 25%. Unilateral diffuse reticular infiltrates of bronchopneumonia in the perihilar regions or lower lobes with hilar adenopathy is also common and can be bilateral in 20% of the cases. Lobar consolidation with bilateral alveolar involvement may be present and may exceed what would be expected based on the severity of the clinical manifestations. The absence of infiltrates may occur in patients immunocompromised. Mycoplasma has been associated with development of bronchiolitis obliterans and organized pneumonia, bronchiectasis, lung abscess, empyemas and lung abscess. There is one case described in the literature, pulmonary embolism, chronic interstitial fibrosis, and ARDS. Also, there is a recent case published this year, a case report of Mycoplasma with positive IgM and serological conversion of the titers with pneumonia and spontaneous pneumomediastinal emphysema and pulmonary bulli. So this slide basically summarizes the multiple radiological findings that can be found in the Mycoplasma pneumonia. So we can have a homogeneous dense opacity, a patch opacity, reticular nodular infiltration, or a bilateral hilar infiltration. So we have, in terms of microbiological diagnosis, we have 3 tests to make the diagnosis of Mycoplasma: the culture, the serology, and the PCR. The culture is laborious, requires a special media, and is expensive, and remember the microorganism is fastidious. So positive specimens may be detected as early as 5 days, or may take up to 6 weeks to confirm negative results. But culture is important to obtain the isolates for antimicrobial susceptibility and or typing. So it is up to 60% sensitive and 100% specific. However, if you have a positive culture for Mycoplasma, we need to correlate with the clinical symptoms, because the culture may be positive if the patient is a Mycoplasma pneumonia carrier. So serology. The ELISA is the most widely used serology in the United States. We have complement fixation, particle agglutination, but ELISAs are the one more used in US. So we measure the antibodies against the P1 adjacent protein and the cardstoxin. In a fourfold or greater rise in acute convalescent phase sera, collect at least 2 weeks apart, is the test that indicates current or recent infection, and is the most accurate is the test that produces the most accurate diagnosis yield. It has a sensitivity of 35 to 75 and specificity of 49 to 100% compared to PCR, depending on, especially depending on the time that the blood is drawn. So usually serology, the IgM is going to be negative in the first 72 hours after the onset of the symptoms, and this is one of the reasons for this wide range of the sensitivity and specificity. The IgM usually is detected around 1 week after onset of the symptoms, peaks in 3-6 months, and then is followed by gradual decline over months to years. It has the highest sensitivity and specificity when compared to PCR if it's done 72 days after the symptoms onset. So now not very helpful in the clinical setting for the acute diagnosis of mycoplasma infection. So reinfections can occur over time and can result in and can lead to a blunting of the IgM response, as occurred typically in adults. So in those cases, the absence of IgM with a positive IgG does not rule out acute mycoplasma infection. A single IgM titer, a titer of 1 to 64 or above, that we use in the practice, and it is marked as immunocards, has the same problems that I mentioned with the IgM serology, because this is an IgM. The specificity is compromised in patients with autoimmune disease, can be false positive, may be absent if the blood is drawn in the first 72 hours after collection of the symptoms, may be absent in patients with immunodeficiency, in the elderly population, and in very young kids. The IgG usually appears 2 weeks after the IgM. So IgA was tested, was started to be evaluated to help with the serological diagnosis of mycoplasma, because it can rise in return to normal value sooner than the IgM and the IgG. However, despite of the attractive idea of IgM, to use IgA instead IgM for the diagnosis of acute mycoplasma infection, several studies have been showing results with negative IgA in patients with confirmed positive culture and or PCR, and also when they compare IgA with paired sera. A combination of IgM and or IgA and PCR has been proposed as an optimal diagnostic approach. However, it is going to result in an increasing on the costs of laboratory testings. PCR, so the NAT. So they use various genes target, including the P1 cytidazine gene, the SER, RNA, the cardstoxin gene. They are available in monoplex and multiplex form, so most of the time, probably that what you have here is the multiplex form that comes with the respiratory viral panel. Despite of the popularity, there are very few studies in the literature doing make a comparison side by side to determine whether one assay format or gene is better than the other. But PCR is important because it allows the detection of the mycoplasma on the blood and CSF, because the culture is rarely positive on those specimens. The PCR can be positive much early in the course of the infection in comparison to the serology. Has 100% sensitivity, 99% specificity compared to culture. Only 2 PCRs natives are cleared by FDA to date to be performed in clinical specimens. The LAMP, that is marked as Illumigen, and the film array respiratory panel that I mentioned a few minutes ago. The PCR can become negative within 24 hours following antibiotic therapy. So we need to correlate a positive PCR with the presence of clinical symptoms, because the carrier status also can result in a positive PCR. PCR remains very expensive, so that respiratory viral panel that we order, at least in my institution, I find out that it costs $700. So it is, and also it is not widely available. So some places they do not have the PCR in house, or they do not have at all. So let's talk about the treatment of mycoplasma. So very recently, in 2015, the Cochrane published article recommending that there was insufficient evidence on the efficacy of antibody for treating Mycoplasma pneumoniae in children. And there are some studies in the literature showing that Mycoplasma pneumonia infection is has a self-limited course, even without antibiotic therapy. Some studies they show that the pneumonia is going to be resolved in 10 days, regardless, without antibiotics. However, recent studies show that the early antibiotic therapy may shorten the duration of the fever. It may prevent the progression to refractory or severe pneumonia. Because Mycoplasma does not have a cell wall, it is inherently resistant to beta-lactams, glycopeptides, and phosphamycin. And also, there are many other antibiotics such as sulfonamides, trimethoprim, polymyxins, rifampin, nalidic acid, and linezolid. They are ineffective against Mycoplasma, leaving very few options for the treatment of this microorganism. So traditionally, the antibiotics used to treat Mycoplasma are the ones that cause inhibition of the bacterial protein synthesis, such as macrolides, chiralides, streptogramins, and tetracyclines, or the ones that cause inhibition of the DNA replication of the bacteria, as the fluoroquinolones. Macrolides are azithromycin, erythromycin, clarithromycin, and the catalides are the most potent agents against Mycoplasma, with very low MICs. So the MIC below 1, if your antibiotic has MIC below 1, is considered able to kill Mycoplasma. So those drugs have a very low MIC. They are equally effective, and they have very high rates of cure, above 90%. Azithromycin and clarithromycin I prefer over erythromycin because they improve tolerability. In the case of the azithromycin, because it has a long health life and allows 5 days course. The 2011 Pediatric Infectious Disease Society of the America guidelines for community-acquired pneumonia recommends for outpatient to treat Mycoplasma pneumonia oral azithromycin for 5 days with clarithromycin or erythromycin as alternative. As inpatient, IV azithromycin and IV erythromycin or levofloxacin as alternative. So resistance is secondary to selection pressure during macrolide therapy. So it's secondary to overuse of the macrolides. Most macrolide-resistant infections have been reported in children because this infection is very common in children, and most of the studies haven't been done in this population. So the resistance is secondary to point mutations on the domain 5 of the peptidyltransferase loop of 23S ribosomal RNA, on the location of the macrolide binding to the 50S bacterial ribosome unit. It causes premature dissociation of the peptidyl transport RNA from the ribosome and eventually blocking the protein synthesis. So here is a picture that shows what I just said. So the circle nucleotides are the sites of the mutations 2063 to 064 that confers resistant to the macrolides. So the mutation A2063 is the most common reported around the world, followed by the A2064G transition mutation. Those mutations, they result in a high level of resistance to all macrolides, with MICs more than 64 micrograms per ml. And they also confer concomitant resistance to streptogrammin B, lincosamides, and ketolides. The mutations haven't been described, but they are much less common. So the first reports of Macrolide-Resistant Mycoplasma pneumonia appeared in Japan in the early 2000s. Subsequently, cases were spread to Europe and North America. And now, over 90% of the Mycoplasma pneumonia isolates are resistant to macrolide in some areas in Japan and China. Lower prevalence is seen in Europe, and the prevalence varies from country to country. 1% in Slovenia, 3.6% in Germany, 19% in the United Kingdom, 30% in Israel. So United States does not have a systematic national surveillance for Mycoplasma pneumoniae infection or Macrolide-resistant Mycoplasma pneumonia. So most of the information that we have about the infection and macrolide-resistant comes from case reports, cases that are described during clusters of the infection, and national surveillance studies. This author here that works in the CDC, he studied Macrolide-resistant Mycoplasma pneumonia in respiratory specimens in some sites in the United States from August 2012 and through April 2014. The study covered a broad geographic area of the U.S., Illinois, Minnesota, New Jersey, New York, Washington, and Alabama. The patient's age ranged from 10 months to 66 years. They collected 91 respiratory specimens. 83 specimens were from patients younger than 18 years of age, so pediatric patients. So they used the real-time PCR to detect the mutations on the 23S ribosome RNA, and they confirmed with the finds with DNA sequence. And then they subcultured the positive specimens to do the antimicrobial testing and susceptibility. So they find high level of macrolide resistance, more than 64 micrograms per ml, in 13.2% of the 91 specimens. The A2063D mutation was the only mutation found. And a striking differences were seen in the erythromycin MIC between the susceptible and the resistant isolates. A striking difference between the two MICs. Erythromycin is used instead of azithromycin during to perform the antimicrobial test susceptibility because the both mutations 2063 and 2064 they have been showing consistent to cause erythromycin and azithromycin resistance. What is the clinical significance of macrolide resistance? So many of us we heard about, but we don't know about exactly how important it is in the clinical practice. So should we worry about that? So we use a lot of azithromycin in pediatrics. Our patients are the population that are in higher risk for Mycoplasma pneumonia infection. So to date, the clinical symptoms, laboratory, and radiographic finds in overall pneumonia severity seems to be similar between macrolide-resistant Mycoplasma pneumonia and macrolide-susceptible Mycoplasma pneumonia infection. However, there is a growing evidence that these drug-resistant infections can result in prolonged fever and cough, longer hospitalization stays, more pronounced chest X-ray changes, in the higher incidence of extrapulmonary complications compared to macrolide-susceptible infections. So the literature has a lot case reports of macrolide-resistant Mycoplasma pneumonia infection. Most of the cases coming from Asia, Japan, China, the areas where Korea, the areas where the macrolide-resistant Mycoplasma pneumonia is become a public health issues. So, in the 2011 Japanese Society guidelines to treat community-acquired pneumonia in the pediatric population recommends macrolides with first-line drugs, but it was in 2011. And toxofloxacin, quinolone, or tetracyclines as second-line drugs in cases of progressive deterioration on respiratory status. Persistent fever after 2-3 days of macrolide therapy is considered one sign of possible macrolide-resistant mycoplasma. Progressive pulmonary consolidation, or the development of extrapulmonary complications. The 2011, the last guideline of the Thoracic Society and the Pediatric Infectious Disease Society of the US about community-acquired pneumonia does not mention about macrolide-resistant Mycoplasma pneumoniae. Maybe because at the time the guidelines were published in 2011, there was not too much data about this subject, and maybe an infrequent occurrence also. Not many cases reported on that time. To date, there is no commercially available kits to detect macroplasma-resistant macrolide-resistant Mycoplasma pneumonia. So if you want to check if there is a suspicion, there are some labs in the United States, like the lab in the University of Alabama in Birmingham. They have the Mycoplasma pneumonia laboratory, and they can test for macrolide-resistant Mycoplasma if you want. So at this point, the recommendation is continues to do a surveillance for macrolide-resistant Mycoplasma pneumonia, and follow up the disease outcome to better define its clinical relevance and appropriate treatment strategies if it become a major problem in US. So there are some drugs that have been developed to treat macrolide-resistant Mycoplasma. So among of them, the solithromycin, that is a catalyst that is derived from the erythromycin, is the one that is on the phase of the clinical trials to treat community-acquired pneumonia. Other therapies to treat Mycoplasma pneumonia infection include immunomodulators. So as I mentioned earlier, it seems like a strong immune response seems to be closely correlated with the lung, the immunopathogenesis of the lung injury and the injury of other organs during the Mycoplasma infection. So accordingly, the use of immunomodulators may have some benefit in cases of a refractory or severe disease. So corticosteroids, intravenous immunoglobulin, and plasmapheresis have been used in cases of severe disease, refractory disease, or in cases where the extrapulmonary infection, extrapulmonary manifestations are present with variable results. I think this is the last. So we still need systematic studies to determine the benefit of the combination of an antibiotic with immunomodulators. We do this in the practice for the severe cases, but we still need to know more about how to use those immunomodulators with the antibiotics to treat the severe cases of Mycoplasma. The optimal dose, duration, time of post-steroid therapy, for example, is still to be determined. So I think this is the last slide, and then come the questions. I do the questions now, Dr. T.
You don't have to. No.
I don't have to?
Yeah.
Okay, so if you have any questions, I'm glad to answer if I know. So thank you for your attention this morning.
So, sure. So I'm interested in moderate to severe mycoplasma pneumonia, and why use LDH as a cutoff for determining whether to use steroids or not? What's the rationale behind that? And then in those studies that showed that if you give steroids when the LDH is high, that they actually showed like a good clinical benefit.
Yes. So there is a very recent study that they do several groups. That was now in 2017, but I saw to be too many slides. And they have several groups that they compare macrolides on, macrolides plus IVIG, macrolides plus steroids. And they check all these. And also, some studies, they check even the levels of interleukin 8 and interleukin 18. It seems like they use LDH because it's more available in the clinical setting that you measure the interleukins. And they show that there is a benefit. This specific study was Dr. Yan. They study refractory pneumonia, severe refractory pneumonia that they define as that pneumonia that has persistent fever with worsening of the symptom, the respiratory status, worsening of the chest X-ray after 7 days on macrolide therapy. And they show that there is an improvement in the groups that had steroids or IVIG compared to the ones that had only macrolides. And there is a decrease in the LDH. I didn't know about the LDH. I looked for, I didn't find exactly why the LDH for mycoplasma, but we know that LDH is not specific for anything. It can increase in many things. So I think they use more like instead they try the CRP and the ESCR, they try the LDH. So, and also because this is more available than the other ones they try, like the interleukin 8 and the interleukin 18. There are studies showing where they do BAL, and they notice that there is a high level of those cytokines in the severe refractory cases. So.
Thank you, Dr.